Hi everyone, and welcome to another training session with Corsmed. Today we're going to look at the pituitary gland MRI. We're going to take it step by step and make sure that you can get every single step and every single image with high quality. I'm going to switch over to the MRI simulator, and let's get started. I have now opened the Corsmed MRI simulator, which is where I will demonstrate how to run the protocol. But before we start, let's ask ourselves a key question. Why do we run a pituitary protocol? The MRI pituitary gland study is highly requested because it helps us diagnose and manage a variety of conditions. Two such conditions are hormonal imbalances and mass effects. And the most common indications for these conditions are hyperprolactinemia, visual disturbances such as bitemporal hemianopia, Cushing's disease, and suspected pituitary adenomas. Now let's start setting up the protocol. We will assume the patient is already positioned in the scanner, head first and supine. I will then go ahead and upload the localizers. To get the perfect positioning, we want the dedicated anatomy to be in the middle of the magnetic field. This helps us avoid artifacts in the area we will focus on today, which is this region here. To ensure accuracy, we must center the laser at the bore onto the glabella. Do not forget this step. Now, before we start with the protocol, we should always first review the hardware settings of our MRI system. The hardware configuration we have selected includes an optimal coil. This coil is physically positioned to provide excellent signal coverage of the sella turcica and surrounding regions, which ensures we get high-quality imaging of the pituitary gland and its nearby structures. We need to visualize the optic chiasm and the cavernous sinuses. These are located more or less in this spot here. You can see the optic chiasm is here. The infundibulum is about here. And here we have the clivus, and you can see the cavernous sinuses here on either side. However, these structures are not yet visible on the localizer. Now, let's finish with the hardware configuration. We are scanning with a 1.5T MRI system and a maximum gradient strength of 45 millitesla per meter. This configuration ensures we achieve optimal image quality while balancing acquisition time and patient comfort. Let's now place the initial localizers. As in a normal brain MRI, the localizers are acquired in the axial, sagittal, and coronal planes. But this time, we will use them to plan sequences precisely for the pituitary gland. This will create a zoom effect, where we will only visualize the portion of the anatomy that we need. Next, we locate central slices here, where we can visualize the pituitary gland and all its structures in detail. These structures include the optic chiasm and the sella turcica. Now, let's move on to the protocol overview. However, I want to point out that there is no single right way to perform an MRI protocol. The setup I will present next is a generally good setup that will work well for most cases, but your organization may do it slightly differently. You should therefore always check if your organization has any specific guidelines for performing this protocol. And if they do, make sure you follow those specifications. So, what sequences does a standard pituitary protocol include? The typical sequences are coronal T2 weighted, sagittal T1 weighted, and post-contrast T1 weighted. If a post-contrast acquisition is required, the clinician will usually suggest it, provided that the patient's renal function is within healthy limits. Because the pituitary gland is so tiny, we will also acquire some additional small field of view and high-resolution coronal T2 scans so that we can see the pituitary clearly. Sometimes we may include dynamic contrast enhanced sequences to help us identify pituitary adenomas. Such sequences capture the adenomas enhancement patterns during the wash-in and wash-out phases of contrast. Today, however, we will focus on just the normal post-contrast and baseline acquisitions. To begin, we will look through the protocol list in the generic brain folder. Once we find it, we will expand it and select the pituitary folder. We will start with a full Axial T2 FLAIR acquisition of the whole brain to check for additional findings outside the pituitary region. We will then focus on the pituitary using small field of view and high-resolution techniques. We will do this for the T1 and T2 sequences. The T2 coronal is optional and may sometimes be skipped if the scan outcome is already clear. For now, we'll add it without positioning. Next, we'll double-click on the T2 FLAIR sequence to start planning it, and we will position the slices perpendicularly. As shown previously in a routine brain MRI, we align the middle slice so that it's parallel to the line that passes through the AC and PC points. That is, the anterior commissure and the posterior commissure. The AC point corresponds to the genu of the corpus callosum, and the PC point corresponds to the splenium. So as you see with the middle slices, we are going exactly through that imaginary line that joins these two spots. Once aligned, we expand the slices to cover the entire brain, from the vertex to the foramen magnum. In the coronal localizer, we adjust the field of view slightly clockwise or counterclockwise to make it perpendicular to the mid-sagittal line of the brain. This line goes through the third ventricle, which you can see over here. We always ensure the field of view is centered in the axial view. Then we adjust its dimensions to reflect the orientation we need. We will use an antero-posterior orientation. We will also minimize the slice gap and slice thickness slightly to achieve finer slices. At the same time, we should always check our scan time to ensure it remains reasonable. If necessary, we adjust the turbo factor or echo train length to speed up the scan. If you want to learn more about sequence planning, watch our video series on scanning routine brain MRI. For now, I will save this configuration. The system will complain about concatenation because the number of slices is not feasible. To fix this, we can either set the suggested number or switch to automatic mode. This prevents similar interruptions and automatically adjusts concatenation when we change TR or slice numbers. I'll now click on Save and then run this pulse. While the sequence is running, we'll focus on the sagittal acquisition using a small field of view and high resolution. First, we'll open the sequence. We will copy the image position from the sagittal localizer. We'll then focus on the pituitary gland. For this, we'll reference both the coronal and axial localizers. Next, we'll align the center of the slice in the coronal and axial localizers directly onto the axial pituitary gland. Once the axial image is available, we can scroll through and identify the point where the pituitary gland is clearly visible. It is more or less here, as you can see, with a noticeable change in density. We'll position the imaging packet exactly over this area. Then we'll reduce the slice thickness and slice gap, keeping the distance factor below 20% or at most 30%. For angling, we'll use the mid-sagittal line of the brain as a reference, which, as we can see, is aligned here in both coronal and axial. I'll twist the angle slightly clockwise to achieve precise positioning. Since we're working with high-resolution imaging, it's not enough to maintain a very small voxel size. We also need to balance it with a thin slice thickness and minimal slice gap to preserve detailed information. Additionally, we can increase the number of averages using up to 5 if the scanner allows. In this area, as you can see here, there are many sections with different tissue densities. Here, we are close to the paranasal sinuses, so anything that appears dark on the images represents air. And air has a very different density compared to the nearby bone. This creates an interface that often results in chemical shift artifacts. To address this, we'll slightly increase the bandwidth. We'll also ensure fold-over suppression is always active to prevent wraparound artifacts from adjacent anatomy. This is why we activate fold-over suppression. It helps reduce artifacts seen both anterior-posteriorly and foot-head. We need to make sure we don't include anatomy outside the intended field of view. Once we've taken these things into account, we will expand the coverage to ensure we include the entire anatomy of the gland. So here, we want to go laterally until we reach the optical nerves, or in a coronal view until we see the arteries or blood vessels on the sides here. Once you are satisfied with the planning, you can click on Save and run this pulse. Since this is a T1 sequence, we will use a short TE and a short TR. With that, we can proceed to scan the sagittal. In the meantime, we'll start planning the coronal sequence. But before we do that, I'd like to open the axial image over here. Or even better, we can load the image into the image viewer. This will help us get a more detailed look at it. Looking at the axial image, I can see here that I have a little bit of coverage of the pituitary gland. It's not very well displayed, but it's just enough to give me the coordinates needed for the coverage we need to adopt. Now, let's take a look at how the sagittal image turned out. As you can see here, the optical chiasm, infundibulum, and pituitary gland with the sella are all very clear. Next, we'll plan the coronal slices. We'll position the slices at a perpendicular angle and adjust the slice thickness. If your scanner allows it, you can copy the orientation and geometry factors, such as the field of view size, matrix size, slice thickness, and slice gap. In this case, we'll finish by positioning the slices at a perpendicular angle to finalize the coronal planning. For the coronal slices, we want them to be parallel to the sella 𝗪𝗎𝗂, located here. So we need just a little bit of anti-clockwise adjustment. In the axial localizer, or reference image, we'll ensure the field of view is perpendicular to the mid-sagittal line of the brain, as seen here. In the coronal view, we need to ensure that we are precisely on the gland. We position the middle of the imaging package exactly on the pituitary gland. And I will also increase the bandwidth slightly. This is important because chemical shift artifacts can occur in this region due to the varying tissue densities. We also need to enable fold-over suppression and select a right-to-left direction. This helps us achieve the smallest possible field of view while minimizing the risk of introducing artifacts. Additionally, we'll add one more average to ensure a high-resolution image. This setup allows us to acquire 9 slices with high resolution in approximately 4 minutes. Once the settings are finalized, we can click Save and run this pulse. For the T2 sequence, we'll simply copy the image position and geometry parameters from the previous coronal sequence. If you need to prepare a contrast injection, you can use the scanner's pause function. On the Corsmed simulator, I will create a pause by adding a generic sequence and then renaming it to pause. Pausing allows us to stop the workflow temporarily to give us enough time to prepare the contrast injection. The injection can be done manually with a syringe or automatically using an infuser, depending on your setup. It's up to you and the guidelines at your center, but I recommend planning your sagittal and coronal T1 sequences immediately after pausing the workflow. This step is crucial because as soon as you inject the contrast, you'll place the patient back in the bore, close the door, and return to the console. At that point, you'll need your sequences ready to go. We will need to perform serial scans to determine the correct time of inversion and begin visualizing the wash-in and wash-out of the pituitary gland. Let's assume I've already prepared my syringe and it's ready to go. Now, I'll navigate to the patient settings, click on Enable Contrast Enhanced Imaging, and set the level of concentration, as well as the contrast agent volume. We will also need to select the timing for when each sequence should be run after the contrast agent is administered. In this case, we'll assume a time of 12 minutes after contrast injection and a contrast agent volume of 10 milliliters. For a patient weighing 80 kilograms, we could inject up to 16 milliliters to meet the appropriate dose. But for today, 10 milliliters will be enough. If the images are not diagnostic, using a bit more contrast can help acquire better images. However, we'll start with 10 milliliters for now. Because we've already planned our sagittal T1 and coronal T1 sequences, all we need to do is name them as post-contrast acquisitions. This makes it clear what kind of sequences they are. We also need to make sure we apply fat saturation to the post-contrast acquisition. This is important because the area we're imaging contains many different tissues with very different densities. And when we use contrast, it leads to shorter T1 times, especially for fat, which tends to appear super hyperintense in T1 post-contrast images. This hyperintensity can sometimes make it difficult to interpret the images, particularly when inflammation is present. To address this, we'll open each sequence, navigate to the special tab, and enable the spectral fat saturation. Normally, we don't need to set an inversion time for spectral fat saturation. However, since this is a simulator, we can manually input an inversion time that most closely matches the fat signal that you'd get at your MRI clinic. For instance, if the fat signal corresponds to an inversion time of 180 milliseconds, we can set it to 180. The right number will depend on your clinic, and they will often have researched which number is appropriate to use. We'll apply this adjustment to both the coronal and sagittal sequences. As you can see, we haven't moved any positioning since the sequences are already aligned and ready to go. Depending on the scanner, we'll either launch the post-contrast acquisition or remove the pause to proceed. We'll now run the post-contrast acquisition and wait for it to complete. While it's running, we should always check on our patient to ensure they haven't experienced any reactions, are not feeling any discomfort, and are still breathing well in a sinusoidal pattern. Here, we already have the sagittal images, and I'll bring up the coronal images here as well. You can see that these post-contrast images are very bright. First, let's review the sagittal images. On the left side, you can see the non-contrast acquisition. Here we can clearly observe the optical chiasm, the infundibulum, the corpus or body of the pituitary gland, and the back of the cella. The post-contrast sagittal images display these structures very clearly, appearing bright and hyperintense. On the other side, I also want to see the coronal image. So I'm going to upload my coronal T1 in the viewport here. Since I've also scanned a T2 and a T1 post-contrast sequence, I have all the images ready here. I will scroll to the slice where we can clearly see the pituitary gland, which is located around here. As you can see, we have the infundibulum extending upward, the optical chiasm, the pituitary gland, the sella underneath, and the clivus. I also want to point out the cavernous sinuses, visible here. Because this structure is very tiny, it's crucial to maintain high resolution. If your scanner allows, you could even go higher than a 256 by 256 matrix, as long as the acquisition time remains reasonable. We can also adjust the contrast and windowing settings to see the structures more clearly. As you can see here, the chiasm, infundibulum, and pituitary gland appear dark in the T2 image. This is because they are surrounded by cerebrospinal fluid. We can also see these structures clearly in slice number 5. In the T1 post-contrast acquisition, the pituitary gland appears very bright and shows clear communication with the surrounding structures. Look at this line. It's the optical chiasm. You can see how it divides, and we can follow its path as we scroll through the slices. These are the key structures we need to analyze for a successful pituitary MRI scan. We must always ensure the optical chiasm, sella turcica, clivus, and sinuses are represented and displayed clearly. Also, we must always consider the surrounding tissues in this region, as this area is particularly tricky. The variation in tissue densities here can lead to chemical shift artifacts if we don't take them into account. So that's it for today. I hope this session has helped you understand the workflow for pituitary MRI scans. The ability to detect subtle pathologies makes MRI the gold standard technique for imaging the pituitary gland. To recap, the key takeaways when you perform this protocol is to use a small field of view, maintaining high resolution, adjusting the bandwidth to minimize chemical shift artifacts, and ensuring we get a proper coverage, acquisition time, and signal-to-noise ratio, SNR. If you check all these points, then you are well on your way to perform excellent pituitary MRI protocols. Thanks for joining, and stay tuned for more.